Hey everyone, thanks for joining us today. We're going to get started in just a few moments. Hey, hello everyone, and thanks for joining us today for our Open Enrollment webinar for the 2025 plan year. Sorry about that. My name is Dori Malazanov, and I'm a senior manager on the Health Systems Integration team at NASTAD. We're also joined today by Molly Tasso, project director for the ADAP Center. We'll have time for a Q&A at the end of the webinar today. Feel free to use the chat if you'd like to share comments or resources with the group. But if you have a question for the presenters that you'd like us to address during Q&A, please use the Q&A function. This just helps us stay organized. Things can get kind of lost in the chat, and we don't want to miss any of your great questions. The webinar is going to be recorded, and we'll circulate a recording and slide deck within a couple of days, along with some additional helpful resources. When this webinar ends, a feedback survey will show up in your browser. It makes my bosses very happy when folks complete these, so please do. It should only take a couple of minutes, and I'll also send a follow-up email with it, and I'll drop it into the chat. So this open enrollment webinar is a little bit different from ones that I've given in the past. In previous webinars, we focused really heavily on marketplace enrollment and eligibility. But due to popular demand, we're going to shift a little more towards Medicare enrollment today. If you're interested in seeing more marketplace-related content, I'd recommend a few things. I'll drop some links in the chat too. First, to peruse recordings and slide decks from NASTAD's prior webinars that are on our website. Second, to check out Health Reform Beyond the Basics. They have annual webinar series about all things marketplace. It's excellent and very comprehensive. I look at it, in fact, all the time. Third, if your staff are in need of marketplace-specific training, please reach out to NASTAD with TA request for that, and we can help develop a training that fits your organization's needs. And finally, visit the ADAP Center. Molly is going to provide an overview today of some of their marketplace-related resources. So today we're going to, let me actually go back. Sorry about that. Today we're going to talk about upcoming enrollment periods for Marketplace and Medicare coverage, Marketplace-related resources from the ADAP Center that you can share with your staff and colleagues at home, the nuts and bolts of applying for Medicare, Medicare Part D changes in the Inflation Reduction Act, Medicare and incarceration, addressing churn and maintaining access, to coverage in 2025 and beyond, and insurance cost effectiveness. I think I saw that someone might have raised their hand. If you have a question or a comment, feel free to send a message to myself or actually to Molly. Molly might be able to see it better because Molly is while I'm presenting, because Molly's not presenting at the same time. So if there's a question about some kind of logistics, feel free to send it to myself or Molly in a chat. I'm gonna just one moving. So with that, let's get started. Both Medicare and private insurance do have enrollment periods coming up. So let's start with private insurance. All healthcare.gov states have open enrollment from November 1st through January 15th. State-based marketplaces do not have to follow the same time frame, but most of them do. Generally, clients must enroll by December 15th for their coverage to start on January 1st. Enrollments completed after December 15th may have a coverage start date of February 1st, which means that the client won't have coverage in January if they don't enroll by that December 15th deadline. But that being said, states with their own marketplaces may have different deadlines for January 1st coverage, so be sure to check the rules in your state. Your state's open enrollment period dates and deadlines also apply to off marketplace plans. So it's something to keep in mind. Same timelines, same deadlines. Before we get into the upcoming Medicare enrollment periods, let's just quickly address when folks can enroll in Medicare for the first time. So when someone first becomes eligible for Medicare, they have an initial enrollment period or an IEP. The Medicare IEP is a 7-month period when the client with the client's 65th birth month in the middle of it. So it's month 4 of their 7-month IEP is their 65th birth month. Some people choose to delay Medicare. Depending on the situation, they might be able to enroll later through a special enrollment period or SEP. SEPs allow people to enroll outside of the standard enrollment periods if they experience certain life changes. So for example, if a client delayed Medicare because they still had employer coverage, but now they're planning to retire, they can transition into Medicare through a special enrollment period. If the client misses their IEP and isn't eligible for an SEP, they can enroll in Medicare during the annual general enrollment period or GEP. The GEP takes place from January 1st to March 31st each year. During this period, clients can sign up for Medicare Part B for the first time. It's also an opportunity for clients to enroll in Part A with premiums. I know a very small number of clients actually enroll in Part A with premiums because it's so expensive, but I just wanted to flag this anyway. If a client joins Medicare during the GEP, their coverage begins the first day of the month after enrollment. Enrollment during the GEP can result in late enrollment penalties or LEPs. LEPs are added to a client's monthly premium and they can be quite steep. In general, the longer the client delayed Medicare, the higher their LEPs will be. On the other hand, if a client enrolls in Medicare through an SEP, they won't have late enrollment penalties. So before enrolling a client in Medicare through the GEP, it is a good practice to just make sure that there aren't any SEPs for which they might qualify, because this could end up saving them a lot of money in the long run. And here I'll just add that to the extent that LEPs are added to a client's premium, and if Ryan White funds are being used to pay for that premium, Ryan White funds can also be used to pay for the portion that's attributable to the late enrollment penalty. I know that hasn't always been the case. I think it was maybe a little before my time since that rule has changed, but I just wanted to flag it because I know that that is something that used to be different. There are 2 other Medicare enrollment periods around this time of year. The next one that's coming up is the annual fall open enrollment period, which runs October 15th through December 7th. This enrollment period is available to clients who already have Medicare. It is not an opportunity to sign up for Medicare for the first time. There are a lot of changes that clients can make during this enrollment period, so it is a good opportunity to evaluate clients' current Medicare coverage and see how it's working for them. And in particular, if a client has Medicare but still needs Part D or wants to change Part D plans, this could be their next opportunity to do that. And changes made during this enrollment period will take effect on January 1st. The Medicare Advantage open enrollment period is also coming up. It aligns with the GEP, the general enrollment period, so January 1 through March 31. As the name suggests, this enrollment period is limited to clients who are already enrolled in Medicare Advantage plans. Clients who have original Medicare or who still need to sign up for Medicare for the first time cannot use this enrollment period at all. During this time, clients with Medicare Advantage can switch to a different plan or switch back to original Medicare. We will touch some more on some of these terms throughout the presentation, but if there's anything that I've just talked about, original Medicare, Medicare Advantage, Medicare Parts A, B, or D, that sounds unfamiliar to you, I highly recommend the ACE-TA Center's excellent Medicare resources, and particularly those about Medicare basics. So I'm going to drop those into the chat just for folks' reference. And on that note, I'm also going to pass it over to Molly from the ACE-TA Center, who will share her screen and walk through some marketplace-related resources before we move on to Medicare enrollment. So let me
Thanks, Dory.
no problem. I think I'm going to stop my screen share, and Molly, I think you should be able to share too.
All right, let's see here. Good afternoon, everybody. Dory, can you confirm that this?
Yes, I see your screen. Okay. Perfect.
Always great. Terrified that I'm showing
Same.
something else, right? Okay. Good afternoon, everyone. My name is Molly. I recognize many names in the chat or in the participant list, but I'm with JSI and the ACE-TA Center, which is a HAB-funded TA center that supports recipients and subrecipients to enroll Ryan White clients into health insurance. So that includes both Marketplace, also Medicare, Medicaid, and also folks who are dually eligible. So instead of showing you screenshots of all of the wonderful technical assistance and training resources that we've developed in the over 10 years that ACE-TA Center has been around, I wanted to very quickly show my screen to also just walk you through. This is our website. So just to show you very briefly what it is you and your staff can access. Again, we are the HAB funded TA center, so everything is free, fully accessible. This here, again, is our homepage. We're on targethiv.org/ACE. I can chat in the direct link afterwards. So here's the landing page. You'll see over here in the menu, we've got it broken out by tools and resources that then lands you into tools and resources broken out by health coverage type. So you've got Marketplace. While I'm here, Dory, I'm just going to show Medicare and then Medicaid as well. Just wanted to show you a few of the great resources. You know, we hear, Dory and I both in our work here, so often that one of the main challenges really facing programs and health departments in general is staff turnover requires so much time and resource providing training and onboarding and capacity building around these what can be fairly complicated topics. And so we hope that these modules that we put together can offer as a great starting place for new staff. So here's one, for example, around understanding PTCs and CSRs, and also getting into the intersection between taxes and health coverage. And so this is a self-guided, fully accessible web module that a person can click through. You'll see here walking through what a premium tax credit is, an APTC, recommended that Ryan White clients take APTCs. Knowledge checks throughout. Again, it's all self-guided. A person can leave and come back. We also have one around how to enroll clients in Marketplace coverage. And so this is starting off with really detailed explanations of eligibility of both types of, health insurance marketplaces. What are we even talking about when we talk about the health insurance marketplace? And then talking about eligibility, and then getting into later on in the module, really sort of the process of helping a client enroll into Marketplace coverage. We have very similar resources for Medicare that I won't show you. We've also got some consumer-facing resources. So this is a great handout that programs can have, subrecipients in their clinics, or even other programs printed and in offices. So this is a consumer-facing tool that is getting at, once a client is enrolled into health insurance, what does it look like? What's the mechanism then for using that? And so this is walking folks through what an insurance card is, how to understand more about their plan, understand the costs associated, and where to go for healthcare. And then just quickly, we've got, again, a very similar setup for our Medicare resources here on our website. We have some great resources around Medicare prescription drug coverage for Ryan White program clients. Again, these are great for both Ryan White case managers and program staff, benefit staff, Also, many of them client-facing, also available in Spanish and Haitian Creole. And then I just want to share this really wonderful fact sheet we have around long-acting injectables, specifically for treatment. And so again, sort of melding the availability of these biomedical interventions or resources with the Ryan White program, and helping folks understand how they can work together to provide great care and treatment to Ryan White clients. So I will stop there. I know that was a ton of information that I've thrown at you all, but I will I'll again share the link directly to our website, and I'll also drop in my email that you all can reach out to me directly, and I'll hand it back to Dory, but you will hear me soon talk about Medicare and the Inflation Reduction Act. So I will talk to you soon. Thanks, Dory.
Thank you, Molly. I'm going to get my screen back on. Thanks everyone for your patience with our back and forth here. Okay. All right. So moving on, let's talk about Medicare enrollment. Just to make sure that there is no confusion, we are talking today about clients who become eligible for Medicare through the age-based pathway, meaning that they're age 65 or older. The rules and processes for clients receiving disability benefits may be different. So eligibility for Medicare is closely tied to eligibility for retirement benefits. If a client is eligible for retirement benefits, their Medicare Part A will be premium free. This is true even if they haven't actually retired yet. If the client is already receiving retirement benefits when they turn 65, they'll likely be enrolled in Medicare Part A and Part B automatically. This is because the application for retirement benefits is also an application for Medicare. Currently, the average retirement age is 62, so that means that a lot of your clients probably will be automatically enrolled in Medicare when they turn 65. But if a client is eligible for, but not yet receiving retirement benefits at age 65, they can still enroll in Medicare, and it will still be premium free, but they'll just have to, Part A will still be premium free, but they will have to actively apply. It's not going to be automatic. Clients who are not eligible for retirement benefits at all when they turn 65 must also actively apply if they want Medicare. But since they aren't eligible for retirement, their Part A coverage is not premium free, and in fact will likely have very high premiums. Clients who already have Medicare when they turn 65, either because of a disability or end-stage renal disease, will just continue their coverage, but any late enrollment penalties will reset. So to qualify for retirement benefits, one must work and pay federal taxes for a total of 40 quarters or 10 cumulative years. This is also the requirement for Part A without premiums, premium-free Part A. So a lot of clients with Part A premiums, therefore, are going to be older immigrants who came to the US later in life and don't have enough work history to qualify for federal retirement benefits. Not everyone with Part A premiums will fit this description, but that will be a group that will kind of disproportionately could end up in a situation where they owe Part A premiums. That being said, keep in mind, though, that clients who are or were married might be able to qualify based on a current or former spouse's work history. If someone is not eligible for retirement benefits and therefore ineligible for premium-free Part A, what are their options? So they can enroll in Part A and Part B. They would owe that Part A premium. They would not receive Ryan White support for that premium because it's not an allowable cost under HRSA policy. However, they could be eligible for Ryan White support with their Part B premium. As a reminder, if a client receives retirement benefits, their Part B premiums are automatically deducted from their monthly retirement check. The client cannot opt out of those deductions, and of course, Ryan White can't reimburse the client. So even though Part B premiums are an allowable cost, in practice, most clients cannot actually receive the support from Ryan White, with the exception, though, of clients who don't receive retirement benefits. These clients are billed directly for their Part B premiums, which means that Ryan White could potentially support with those. A client who owes a premium for Part A is not permitted to enroll in Part A only. They can, however, enroll in Part B only, which would still allow them to add Part D prescription drug coverage. In this case, the client wouldn't have coverage for Part A inpatient services like hospitalization, which is concerning, but they would have Part B outpatient medical coverage and Part D prescription drug coverage, both of which could be eligible for Ryan White assistance. Clients may also decide to enroll in private coverage instead of Medicare if that's available to them. Or if they're eligible for Medicaid in their state, that could also be an option. So now I want to talk through some of the nuts and bolts of applying for and enrolling in Medicare. First, there's Medicare Part A, that's inpatient coverage. As I said, clients receiving retirement benefits will be automatically enrolled in premium-free Part A. Clients who aren't yet collecting retirement benefits will have to actively apply. So clients can enroll in premium-free Part A at any time after they turn 65, online or by paper application. The client can also apply for Part B at the same time, assuming that they're in a valid Part B enrollment period. They can choose to delay Part B, but unless they have employer coverage or are incarcerated, it's usually going to be in their best interest to apply for both Parts A and B soon as they're eligible. Clients who owe Part A premiums can sign up for Part A not anytime that they want, like clients with premium-free Part A. But Part A premium enrollment is available during a client's initial enrollment period, their IEP, the annual general enrollment period, the GEP, or a special enrollment period, an SEP. And again, because they owe Part A premiums, they must sign up for Part B as well. They can't just sign up for Part A. I actually would love to do a really quick informal poll here. If you have ever done a Medicare application, actually not ever, if you've done a Medicare application on paper in the last few years, up to 5 years, drop a number 1 into the chat. Folks are here and can find the chat. Hooray, thanks y'all. Okay, so looking like so far not many, unless there's just people who don't want to respond. Okay, that is really great to know. I included these I kind of figured that might be the answer. I included these paper applications anyway because they're actually really good resources. They have really useful information on them about how the Medicare application process works. So even if your clients aren't using these paper applications, they can be kind of surprisingly helpful in figuring out, what next steps are and what to do and where to go when clients are ready to apply for Medicare. So I recommend looking at them anyway. Okay, Part B enrollment, that's outpatient care, things like medical visits, lab visits, mental health visits, etc. Clients eligible for premium-free Part A are not really able to decline it. So if they're signing up for Part B, they'll also have to sign up for Part A. Again, they can sign up for premium-free Part A at any time and then enroll in Part B during a valid enrollment period, which again can be done online or by paper application. If the client owes a Part A premium, they can decline it and enroll in Part B only. Part A is only required if it's premium-free. So if a client is interested in enrolling only in Part B and not in Part A, that can be done as well, but they will potentially have to call Social Security to apply. There's not an online application that I'm aware of for applying for only Part B under these circumstances. There is, however, a paper application for certain SEPs. Here are just some links to the paper applications that I've discussed today for your later review. So those last few slides cover enrollment in Original Medicare. Original Medicare is when Part A and Part B coverage is provided directly by the federal government on a fee-for-service basis. Once a client has Original Medicare, they can choose to switch to Part C, also known as Medicare Advantage. These are private plans that provide Medicare coverage, and they work similarly to other private insurance and are offered by private insurance companies. Medicare Advantage has an initial coverage election period, or ICEP, which is the period when someone can enroll in Medicare Advantage for the first time. Clients must have both Medicare Parts A and B to enroll in Medicare Advantage. So therefore, the timing of the client's initial coverage election period is going to be tied to when they have both Parts A and B. Most Medicare Advantage plans also include prescription drugs, but if not, then a separate Part D plan would be needed. Clients who stay in original Medicare will also need Part D coverage. This is prescription drug coverage for Medicare enrollees, which is also provided by private plans. Some clients are automatically enrolled in Part D, which we'll discuss a little later, but for those who are not, they'll have to actively enroll. Once a client has either Part A or Part B, they don't need both. They can enroll in a Part D. They can enroll in a Part D plan during their Part D initial enrollment period, which usually aligns with their 7-month Medicare initial enrollment period. So that's how folks can sign up for Medicare Advantage or Part D for the first time. Here on the right side, I've just put some of the enrollment periods that we talked about earlier, because these enrollment periods also provide opportunities to make changes to a Medicare Advantage or Part D coverage. And if you haven't seen it yet, I do recommend checking out Medicare.gov's new and improved plan comparison tool. I've linked to it on this slide. You can use that website to help clients assess their options and to enroll in Medicare Advantage or Part D. Outside of these initial enrollment and annual enrollment periods, there are also special enrollment periods, or SEPs. For Medicare Advantage and Part D, there are about 21 different SEPs. So I've just listed a few of them here, and I provided a link for a great resource that lists all of these SEPs and how explains in detail, how they operate and how clients can use them. So I definitely recommend saving that one when the slides come around. One important thing to note about SEPs for Part D is that if a client doesn't enroll when they first become eligible, they'll likely pay an LEP. Molly, there are no guests. One thing that's important to note about SEPs for Part D, if a client doesn't enroll in Part D when they first become eligible, they'll likely pay an LEP even if they enroll later through an SEP. So for Part D, that initial enrollment period is going to be really important. On the other hand, if a client enrolls in Medicare Part A or Part B using an SEP, they won't have any LEPs. So there are generally, so that's the difference there. Part A and Part B enrollment through an SEP, no penalties. Part D enrollment through an SEP, likely penalties, with 3 exceptions. If the client delayed Part D because they had other coverage, creditable coverage, if they were misinformed about whether they had creditable coverage, or if they qualify for extra help. And creditable coverage is coverage that's at least as good as the basic Part D benefit. A little bit about extra help. This is a program that helps low-income Medicare enrollees with their Part D premiums and out-of-pocket costs. It's also referred to as the Part D Low-Income Subsidy, or LIS. As of January 1st, 2024, there is no longer a partial LIS. Sorry, sending a little note to Molly there. So that means that all LIS enrollees with incomes up to 150% of the federal poverty level will have no premiums and no deductibles. So there's no more partial LIS. Everyone receives the full LIS benefit, but there are still 2 cost-sharing tiers. So some clients will have lower copays for covered drugs than others. Clients eligible for extra help will be automatically enrolled in a Part D plan unless they actively enroll in one themselves. The client should receive a few different notices from CMS before that happens, and they'll have the opportunity to change the plan later if they don't like it. If a client is auto-enrolled in Part D, it may take up to 2 months for their drug coverage to start. During that gap, they could be eligible for LINET, which is kind of like a temporary gap coverage that's provided, administered through Humana, and there's a link on this slide that'll go around where you can learn more. I don't want to spend too much time on Medigap's today. I just want to, there's a lot of information here for folks to, peruse at your leisure. I just want to briefly discuss what they are. They are plans that help fill the gaps in Medicare coverage by paying outstanding deductibles, copays, and coinsurance for Medicare services. Clients pay a premium for them, which Ryan White funds can be used to support with that. There are very limited opportunities when a person can enroll in a Medigap policy and have a guaranteed right to buy a policy. Outside of their first 6 months of Medicare eligibility or other limited situations when clients might have a guaranteed issue right, Medigap could be a challenge to purchase. Insurers would be able to deny the coverage, charge higher premiums, impose long wait periods for pre-existing conditions. But if clients are able to enroll in Medigap as soon as they become eligible for Medicare, or when they have one of these narrow guaranteed issue rights, that will make the Medigap more accessible, available, and affordable to the clients. The protections that are summarized on this slide apply nationwide, but some states also have their own protections that would provide additional enrollment opportunities in Medigap. So make sure to check the rules in your state. We know that programs are paying Medigap premiums for your clients. So we would love to know actually how that's going. So I'm going to launch a quick poll if I can figure out how. And I would just love to hear from folks whether you've experienced any challenges with making premium payments for Medigap plans. And if your program doesn't pay Medigap premiums for your clients, you can just choose NA. And also, if you said yes and you're open to sharing with the group, I'm sure folks would be really interested to know what issues their peers are facing. So if you're open to sharing, feel free to drop some details in the chat. Even if you don't want to share, please still don't hesitate to reach out to me for technical assistance with those issues. Okay, looks like we have a good mix of folks who, of those who do pay Medigap premiums. There's been a range of experiences. Great, thanks. I'll let that stay up there for a little bit for folks to keep responding, and I will move on. So let's talk a little bit about dually eligible clients. These are clients who are eligible for both Medicare and Medicaid. There are two ways that Medicaid supports Medicare clients, through two primary ways. There's ABD Medicaid, which provides full Medicaid benefits, and there's also Medicare savings programs. Clients with ABD Medicaid receive full Medicaid benefits wrapped around their Medicare. Medicaid can also cover some additional services that Medicare doesn't cover, like non-emergent transportation. And Medicaid can also cover outstanding client cost sharing for Medicare services. Clients eligible for Medicaid are usually also eligible for Medicare savings programs, or MSPs, to help with their Medicare costs. There are 4 types of MSPs, which are listed here. Depending on the client's income and assets, they might be eligible for assistance with Medicare premiums or cost sharing under one of these programs. How does a Medicare client apply for Medicaid? The first step is to call their local Medicaid office to learn how to apply and what requirements and processes are going to be needed in their state. This might not be as intuitive as you would hope, and it could really vary depending on where you live in the country. So calling the local Medicaid office is the first step. Once the client is duly enrolled in both programs, they'll usually be automatically enrolled in an MSP or extra help as well. ABD Medicaid is a very important source of Medicaid coverage for Medicare enrollees, but there are also programs for clients who need home and community-based services or institutional care. And unlike Medicare, clients must recertify their Medicaid eligibility every year. I'm going to just talk a little bit about Part A conditional enrollment, and then I'm going to hand it back to Molly to talk about Part D changes. And apologies that I messed up a little bit of my own planning with today, some math errors. So we might not get through all of the private insurance topics, but I'm happy to revisit any of them with folks later. Deep apologies for that. We'll get through as much as we can. Okay, so the MSP that pays Part A premiums for clients age 65 plus is the QIMBY, Qualified Medicare Beneficiary Program, or QIMBY. On the last slide, I noted that a client must already have Part A before they apply for an MSP. So what happens if the client owes Part A premiums, but they can't afford it without QIMBY? How can they meet that requirement of already having Part A before they apply for the MSP? So the conditional enrollment process addresses this problem by allowing the client to enroll in premium Part A on the condition that the state approves their QIMBY application. So it's a two-step process. The client first goes to their Social Security office and asks to apply for conditional enrollment. Then they bring proof of their conditional enrollment to the Medicaid office, and they can apply for Medicaid. And if they're denied QIMBY, they won't be enrolled in Part A either, because it was a conditional enrollment only to be kind of completed on the condition that they get into QIMBY. There are about 14 group payer states where clients, they're listed on the bottom of the slide here, where clients can apply for conditional enrollment only during the annual Medicare GEP. The remaining states are Part A buy-in states, where clients can apply for conditional enrollment at any time of year. Part A buy-in states also allow clients to bypass the conditional Part A enrollment if they already have Part B. They can just take their Medicare card to the Medicaid office and apply for QIMBY. They don't have to do both steps if they already have Part B and if they are in a Part A buy-in state. And here, this just summarizes some of the things that we talked about today. A couple of things I just wanted to highlight for your memory. First, conditional enrollment is kind of difficult. And even in my own personal experience, and also from knowing what other advocates have reported, Social Security office staff don't always necessarily understand the proper procedures for how to handle a Part A conditional enrollment. I think, folks with Part A premiums who are eligible for Medicaid are probably not like a huge group, and there's just some offices where folks just haven't come across it as much and might not know what to do. So the client should make sure to state that they are applying for conditional Part A enrollment. If they can refer to the relevant section of the Social Security Program's Operation Manual, if that's helpful. And they should also ask for a screenshot of their application and bring it to Medicaid in case Medicaid is unable to verify for some reason that they've already applied for conditional Part A. A reminder that, Medicaid, even for folks while Medicare doesn't have to be recertified every year, Medicaid does. So, and Medicare clients with Medicaid will still have to do that process every year. Clients with Medicaid should make sure to keep their Part D coverage. They're allowed to disenroll from it technically, but Medicaid will not cover their prescription drugs if they have Medicare. So they need Part D if they want the drug coverage. And finally, each state has different rules for counting assets and income. So clients should still apply for Medicaid and MSPs, even if it seems like they might be over the limit. So to kind of sum up some next steps after Medicare enrollment before I pass it to Molly to get into Part D changes. Folks who are nearing Medicare age are going to get a Welcome to Medicare packet in the mail about 3 months before their coverage starts. It explains some important decisions that clients need to make after they enroll in Medicare. If they already have Part A and Part B, they can consider Medicare Advantage if that's a good fit for them. Clients who have employer coverage can decide whether they should keep that coverage or switch to Medicare. The Welcome Packet will explain how to decline Part B in that situation. After the client has Medicare, they can consider whether they might be eligible for Medicaid or an MSP. Remember that some MSPs pay Medicare Part A premiums, which Ryan White is prohibited from paying. And MSPs also pay Part B premiums, which Ryan White is logistically prevented from paying for most clients. So MSPs could be the only way for many clients to get any kind of financial assistance with their Medicare premiums, Part A and Part B premiums. Once the client has Part A or Part B, they can assess their Part D options. If they're automatically enrolled in Part D because they have extra help, they can switch plans if they're not happy with it. And clients age 65 plus with Medicare Part A and Part B can consider whether Medigap is a good choice for them. Remember again that the timing for Medigap is critical because Medigap coverage is only guaranteed under limited circumstances. Now I'll pass it off to Molly from the ACE-TA Center to talk us through some important Medicare Part D changes. And then I think we'll have time to potentially, run through a couple of private insurance related updates. So I'll pass it off to Ed before questions. So I'll pass it off now to Molly.
Awesome. Thanks, Dory. So I'm going to walk us through a couple Medicare provisions that were part of the IRA, the Inflation Reduction Act, which was passed in 2022. And it was a massive piece of legislation that focused on healthcare, climate, and energy policy. And it really had significant changes to Medicare benefit design and prescription drug access. On the next slide, two very high-level snapshots of a couple changes that I'll get into over the next couple slides. The first being the elimination of the 5% coinsurance in the catastrophic coverage phase. That began in January of this year. So beginning this year, so currently taking place, there's no longer a 5% coinsurance once an enrollee hits that catastrophic coverage phase. And then beginning January 1 of next year, 2025, is a $2,000 out-of-pocket cap for Medicare Part D cost sharing. This is a huge, wonderful change. And so we'll get into that a little bit in the coming slides. But these are two great sort of price-related or cost-related changes that came out of the IRA. Just given timing, I won't get into I won't get into too much of the weeds here, but what we're seeing here is how the Medicare Part D cost sharing phases as it's currently operating here in 2024. So as we know, a person has their deductible in 2024. This year, the deductible was a planned deductible couldn't be higher than $545. So you're seeing that, and enrollee pays that. You move into the initial coverage phase where an enrollee is paying 25% coinsurance, let's say, until total payment reached is $5,030, which is the most amount of money that can be paid in that initial coverage gap. Then a person moves into the coverage gap, where an enrollee is paying again 25% coinsurance until total spending from both the plan, manufacturer discounts, and the enrollee reaches $8,000. And then without that 5% coinsurance for the catastrophic phase, an enrollee would have $0 in cost sharing once that catastrophic phase is hit for the rest of the plan year. Moving into the next slide, it becomes much more simple, right? And so I realize I think there's an error here. I believe the maximum deductible amount, I believe for next year is $590, not $540. But for example here, an enrollee pays 100% up until they hit their deductible. And then they move into the initial coverage phase. And then that person is moving along paying 25% coinsurance until spending reaches $2,000. And then that's the cap. That's it. No more additional phases if they reach their $2,000 out of pocket before moving out of the initial coverage phase. Once they hit the $2,000, the enrollee is paying $0 in cost sharing for the rest of the plan year. So again, a really great, wonderful change that's increasing, lowering costs, increasing access, always a wonderful thing. On the next slide, you'll see, just as a quick sort of a case study, if you will, specifically a Ryan White client or someone living with HIV, they're going to reach that $2,000 cap pretty quickly. On the next slide, you'll see just for an example. So let's say someone is prescribed a single tablet regimen, has a negotiated price of $3,100. In January, the enrollee payment is $1,500. And also, to be clear, when I say enrollee payment, that's also accounting for payments made by ADAPs on behalf of a client. But they're paying, let's say, $1,500 in January. In February, all they need to pay is $500. Not all they need to pay. It's quite a hefty payment, but they're paying that $500 that gets them up to that $2,000 cap, and then they're done. No more cost sharing for the rest of the plan year. a wonderful thing. I will note though, however, and I'm sure many of you sitting here in this Zoom room are picking up on this as well, that ADAPs are able to generate rebates on the cost sharing it pays on behalf of an ADAP client. And so in those months, March through December, where there are no cost sharing payments required, those are rebates that ADAPs are not generating. And so that is a reality that I know Dory and others at NASTAD are quite attuned to, and working with many states, I believe, already on sort of forecasting the implications and just sort of the budgetary realities of what this will mean moving forward. But I always come back to decreased costs, increased access to healthcare, to health coverage, to medication is necessarily a good thing. So moving on to another component, a significant piece of the legislation of the IRA is the creation of the Medicare Part D prescription payment plan. You'll also see this referred to as MPPP, some people MP3, M3P, or smoothing, a lot of names for it. But essentially it's a program starting in January of 2025, so this upcoming January. And it's a program that allows folks to smooth their prescription drug costs sharing over the course of the plan year. And so think of it as like a 0% interest credit card or a payment plan, something along those lines. It's not decreasing costs. It's not lowering the total annual cost sharing a person will pay for their prescription drugs. It's just smoothing it over the plan year. So that's a nice way that we talk about and explain to folks of what this program is. The program is not for everybody, and so we want to be very clear about that. The program is really, it is available to anyone, I should say that, but it is expected to be most helpful for enrollees who have high cost sharing earlier in the plan year. And when Medicare Part D and Medicare Advantage plans are reaching out to enrollees to explain to them what this program is, and to offer them the option of enrolling and opting into the plan, they're going to be reaching out to folks who paid at least $2,000 in Part D cost sharing in 2024, and then also those who were expected to incur out-of-pocket costs of $600 or more for a single medication in 2025. So there's some sort of targeted outreach going on there. Again, out of recognition that this is a program that will be very beneficial to some folks, but really isn't sort of broadly, I would say, maybe the best route for folks to go in terms of managing their costs throughout the year. So, excuse me, on the next slide. So I'm just sort of logistically how it works. So when someone opts into the MPPP, MP3 plan, they are making the monthly payment directly to the Part D plan. And this is separate than the plan's premium. And so they pay nothing when they go to the pharmacy to pick up their medication. So just things in terms of the ADAP component of it, payments made by ADAPs or SPAPs or other third-party payers, those payments, especially as it relates to ADAPs, all of that will continue to operate as they do. If a client comes into a pharmacy and picks up a medication, has their ADAP card, that payment will be processed. Anything left over though, that amount could be subject to smoothing, perhaps if they have another medication that isn't covered by ADAP. And that's where we're going to talk in a couple slides about whether or not it maybe makes sense for a client to enroll into the smoothing plan. So on the next slide, again, just showing a little bit of a case study of how this will work. So I'll just say up front, because it's not on the slide, remember that in this scenario, there's a $2,000 out-of-pocket cap. So that's why you're seeing no additional payments really made beyond January. But what you're seeing here is a client goes in to a pharmacy. They've had a couple of medications. One is covered by ADAP. Another one of them is not covered by ADAP. The ADAP is making that $1,300 payment made directly to the pharmacy on behalf of the ADAP client for that ADAP covered drug. Again, that's exactly how it's operating today. Nothing there changes. For that non-ADAP drug, that costly non-ADAP drug, a person could choose to opt into the smoothing program for that drug. And what you're seeing here is that $166.67 and then the $40.28 payments. That will equal the $700 that gets a person to the $2,000 cap. So in February through December, they're just paying those payments for the January cost for that non-ADAP drug. But because they've hit their $2,000 cap, there are no additional out-of-pocket costs incurred throughout the year. So sort of stepping back, we don't feel it doesn't make a whole lot of sense most of the time for a Ryan White client to enroll into the smoothing program. If a Ryan White client can expect that all of their Medicare Part D cost sharing will be paid for by ADAP, they should not enroll into this program. Even if a client needs to access meds that are not on the formulary, again, they should remember that there's that $2,000 annual out-of-pocket cap starting in January. And so it will often be the case that cost sharing payments made by ADAPs on behalf of a client, you're going to reach that $2,000 cap pretty quickly, right? January, February, March, maybe at the latest. And so cost sharing for non-ADAP formulary drugs filled after that $2,000 cap has been reached will have a $0 cost sharing payment. So there could be a scenario where a client, again, has a non-ADAP formulary drug that for whatever reason there might be some flexibilities on when that person chooses to fill that drug. And if their out-of-pocket max is being met in January or February, it could make sense that a person would wait to fill that drug until March, which would then, which would then allow the person to access that drug with 0% cost sharing. There are a few questions that remain on the final slide here, just about the sort of administrative logistics. For example, what happens if a person enrolls in the program and has back payments due to the Part D plan? Can ADAP perhaps make payments for that person make payments on behalf of that person? The answer is probably yes, but no rebate will be generated. And I think the logistical piece of that is still the mechanism by which an ADAP can make payments to a Part D plan for these smooth payment amounts, I think will need to be figured out. But I believe that there would be no reason why I believe an issuer would not accept or take those payments. Also, other questions or just considerations. Will a Part D plan be required to accept payments from ADAPs? Sort of getting to my previous point. And how will, this is the big one for us, is how will we all, and I'll include like Ryan White assisters and clients, case managers, admin, benefit staff, how will we be notified about this plan, the availability of this program? How will we know about this to inform clients about their options and to hopefully avoid confusion? So these are some questions that I think as things roll out over the next couple of months, open enrollment is starting in early August or early October. So we will start to see folks, and I believe Dory has seen some outreach conducted by Part D issuers. So we will gather more information. We will have a better understanding of how issuers are talking to clients about this, but it's something for all of us to be aware of and to be mindful of when talking with clients about enrolling into Medicare. Know that this is a possibility of an option for them, and we should all be prepared to talk with a person through the pros and cons of potentially enrolling. That was a very, very quick, very high level overview, and I apologize for that. I will say JSI, ACTA Center, and NASTAD together, we are doing a webinar in late October focused solely on this issue. And so I don't have the registration link today, but if you want to get in touch with Dory or myself, we'll be sure to get you the registration link. It will be 90 minutes with Amy Killalay and Dory and Jeff and myself and Tim Horn. So all the experts on the line ready to answer your questions. So please be sure to to register for that. All right, Dory, back to you in 4 minutes.
Okay, thanks, Molly. Again, apologies a little bit for my misplanning here. So we're gonna not really have a chance to get through Medicare and incarceration, but there aren't really any questions and we have a few minutes left. So I just want to address a couple of things that I think are especially important right now. Here's like a list of some federal policy updates that are salient for this year. I'm just going to highlight a few of them for today that I think are especially important. First, the Medicaid renewals for unwinding will continue through the end of 2025, which actually happened too late to even make it onto this slide. So renewals are still going to be, unwinding related renewals will be continuing for another year. And the unwinding SEP is still available. So clients don't have to wait until open enrollment to apply for coverage if they need it now. There are strengthened non-discrimination protections that were passed. There were strengthened protections for reproductive health care data, all really exciting and relevant directly, or indirectly to our work in our communities. And in terms of the marketplace, one important thing that's going to be happening this year, not really a change so much as a resumption of an old policy. Clients who fail to reconcile advanced premium tax credits for at least 2 previous years will potentially be prevented from getting tax credits in the upcoming open enrollment. This requirement was suspended for a few years there during the pandemic, but those failure to file and reconcile operations are back in place this year. And but will be there's a small change in that a client has to fail to file and reconcile for 2 years in order to be excluded. This is not something that I'm going to get into detail today, but I know there's been a lot of interest among folks to understand how special enrollment periods apply to off-marketplace plans. So here you are, I have found it. There is a regulation that very clearly states which SEPs apply and don't apply, which SEPs are accepted or from the off-marketplace market, but otherwise other SEPs, unless they're on that list, are going to apply. So what's important to know here is that if your clients are applying off marketplace and they're eligible for an SEP, in all likelihood, they are eligible to use it to apply in that plan. And if you're not sure, or the plan is giving you some kind of different information, please reach out to me and I can help you kind of clarify what's going on and help advocate for the client to be able to enroll. This is kind of my usual content that folks can also peruse our old webinars for just some reminders that as you're going through open enrollment and beyond, to continue screening clients for coverage, making sure to make changes if their circumstances change, cautioning them against bad coverage, and helping them maintain coverage throughout the year and partnering with enrollment assistance organizations. So sincere apologies that we didn't get to do those in more details. But I'm gonna stop apologizing. I'm just gonna keep it moving. Insurance cost effectiveness, as a quick reminder, cost effectiveness is assessed at the aggregate program level, not at the individual plan level. So if an individual client has a really expensive plan, it's way more expensive than everybody else's, it doesn't mean that the program can't pay for that plan. What matters is that insurance purchase is cost effective in the aggregate compared to traditional full pay ADAP, and it will, I think, usually be. So something to remember as we move forward. And also as you're considering cost effectiveness, to remember that the net costs of both insurance and drug purchase are to be considered there, inclusive of discounts and rebates. And stay tuned for NASTAD's upcoming insurance cost effectiveness tool, which can help you estimate rebates relative to premium and cost sharing payments under each plan. So thank you everyone for coming. Sorry for the quick wind down. We did get to talk about almost everything. Medicare and incarceration will wait for another day when we can give it more at the attention that it's due. In the meantime, here's our contact information. Please feel free to reach out to Molly or myself with any questions. I know that there was another DSHAP webinar, I think it was before this, and folks might have been a little bit late coming here. So if you like to, I can stick around for another minute or two if folks have any questions or want to talk about things that they missed. Otherwise, thank you and enjoy the rest of your day.